All right, good evening, everyone. We're at the hour now. Thank you for tuning in to this evening's SSAT's webinar on preparing for the general surgery boards. This is slated to go from 7 to 8 p.m. Eastern time, and we'll try to stay on time. My name is Zhi Ven Fong, and I'm a surgical oncology fellow at Massachusetts General Hospital. My co-moderator is Maria Altieri, who is also the chair of our SSAT Resident and Fellows Education Committee. She's also the pioneer of SSAT's webinar programs and made it what it is today, so we have her to thank for being here today. And really quickly, some house Zoom rules. Please mute your microphone when you're not speaking so we keep the background noise to a minimum. If you have any questions, please list them in the Q&A section at the bottom of the screen, and I will go through them at the end of the webinar. And I'm going to pass the mic to Maria right now, who will speak a little about the SSAT before we officially begin the webinar.
Thank you, Z, for that kind introduction, and thank you for co-moderating with me. I also would like to thank you all for being here today on the behalf of the Resident and Fellow Education Committee. Just very briefly about the SSAT, which stands for the Society for Surgery of the Alimentary Tract, which was founded in the 1960s as the Association for Colon of Surgery. The mission is to lead in advancing the science and practice of gastrointestinal surgery, and the vision of the society is a global community of gastrointestinal surgeons advancing research, innovation, and advocacy to benefit interdisciplinary patient care. See if you can just fast forward one slide. Just a little bit about the membership categories. Most of you are candidate members. It's actually fairly priced. As annual membership is only $20, and you have a lot of benefits. If you can just move to the next slide to describe the benefits. And both me and Z can vouch for the leadership opportunities that we have had through the society, as well as also access to the Journal of the Gastrointestinal Surgery, deeply discounted early bird registration to DDW, which is basically the meeting for our annual meeting, and access to apply for awards, grants, scholarships, and traveling fellowships. And Z, if you can just forward one slide as well. I just wanted to briefly get your attention to the Resident Corner, which is a very invaluable resource for residents, and has information such as outside quizzes, Mentor of the Month series since 2014, surgical meeting calendar, video library, and of course our past webinars, which are such a great resource. And if you can just fast forward. So with no further ado, I would like to welcome our first speaker, Dr. Timothy Nelson. Thank you, Dr. Nelson, for being here. He's representing actually the American Board of Surgery. Dr. Nelson is a professor and chair of surgery at University of Oklahoma at Tulsa, and he's also currently acting as the chair of the general surgery boards for the American Board of Surgery. A little bit before his talk, I just wanted to make a brief disclaimer that none of the rest of the talks are actually endorsed by the American Board of Surgery, nor the scenarios, but the information is extremely helpful, and the talk that Dr. Nelson will share with us, which is changes to the certifying and qualifying exams, our virtual examinations here to stay, is the only talk that is actually endorsed by the ABS today. Dr. Nelson, thank you so much for being here, sir.
All right, let's see if I can get my screen share working. Are you seeing it correctly? Good. So it's a pleasure to be here. Thank you, Dr. Altieri, for the opportunity to talk a little bit on changes to the certifying and quality exam. Are virtual examinations here to stay? I can give the answer, yes, and not always. And we could probably stop there, but since I got about 9 more minutes, I'm gonna keep talking. So the first is, I'm glad you shared the vision and the mission of the SSAT, because it's important to understand the vision and the mission of the organizations that you interact with. This is our vision. The American Board of Surgery is to unify surgery in the pursuit of excellence in patient care. In our mission, I'm not going to read all this, but I want to emphasize the American Board of Surgery serves the public and the specialty of surgery. And we take very seriously that we serve the public. That's actually our first point of service when we look at our entire mission. But of course, we do that by interacting with our diplomats and people who are in the process of becoming diplomats, which is most of you who are on the call today. So we're really good at what we do in terms of giving examinations and using those to determine how people are ready to go out and practice surgery. And we have a long history of refining it and a very scientific approach to it, and really had things pretty nailed. And then this little guy came along y'all know this is the coronavirus that completely disrupted all of our lives about a year and a half ago. And I remember sitting in March when it was becoming apparent that we weren't going to be able to do things the same way we had done. And for the General Surgery Board, because although we have 5 specialty boards in the American Board of Surgery, the General Surgery Board is both the oldest and the newest, but also has the most folks that come through it and need to be examined. And we could see, one, that the certifying exam, which you call the oral exam, was going to have to be totally changed, because the idea that people could travel and be in a hotel room with other people was clearly not going to be possible. So we were scrambling on that. But at the same time, we were scrambling for how we were going to do the qualifying exam, the written exam, because we had a standard way of doing this where you went into a person center and you took the exam, you sat down and did it. It was very secure, it worked very well. But those were closing down, and we were not sure. We had to make a decision quite a few months in advance about whether that technology was going to work. And we guessed correctly that it wasn't, it wouldn't have been available. So we decided, well, if our number one plan, sort of like if you think of flying, going from Europe, from the United States over to Europe, you'd take a plane. Well, if planes suddenly aren't flying anymore, you need a backup plan. So we developed a backup plan. And in doing our backup plan, we said, well, we got to have some principles that we're going to do. And one of our principles were, as a healthcare organization, we couldn't do anything that would endanger the public more, specifically all our candidates who are becoming diplomats and their families. We really couldn't expose people to COVID-19. This was a scary time in COVID-19 where we saw a lot of people dying, and we were concerned about it. The other is that we had been one of the proponents of having a nice timeline for folks, and we're a strong proponent of moving the start of most of the fellowship dates to August 1st to allow that month of July. You finished your general surgery residency, you have time to transition in your life, move your life, study for an exam, even maybe take a little time off. And we really wanted to honor that time if at all possible. So we came up with our plan B, which was, if you can't fly, you could take a ship to get across the Titanic. So we came up with this idea of having virtual exams that people would do in their home with virtual proctors. This is a picture of the Titanic, and our plan to use virtual proctors was a little bit like the Titanic crossing the Atlantic. It did not work well at all. And we learned a lot of lessons from that. We learned that live and AI proctoring puts a large burden on the candidates. They needed devices, they needed secure, quiet places. A lot of people were in the process of moving, so even finding a quiet place was a problem. That the proctoring itself was very intrusive. It was kind of creepy to people to have these proctors. It sounded like a good idea, but it didn't work well. And then the whole thing melted down. And the technology and culture are not mature, and we realized we can't rush, and we couldn't do that. We had to shut down the exam, and it caused a lot of people a lot of distress. It caused a lot of distress for those of us who work for and volunteer for the board, but more importantly, it caused a lot of distress for people just like you who are taking the exam. And I'm going to take this moment again to apologize on behalf of the American Board of Surgery for the pain that we caused people, because we felt awful about it, but more importantly, it caused a lot of pain. But we did say, okay, so that didn't work. Our backup plan didn't work. We got to come up with another plan. And we took some time again to have some principles. We had to recognize the negative experience of that exam, but we also had to allow equitable access and certification in that academic year, maintain exam security and reliability, and maintain the standards set by both the ADS and ABMS. And we wanted to do that not just for ourselves as the American Board of Surgery, we wanted to do it for the candidates who became diplomats. We didn't want anyone to feel like they had an asterisk next to their name for their certification. Their certification was exactly the same quality of certification that everyone else years ahead of them, years after would get. But we also wanted to come up with a plan that would minimize the likelihood of widespread disruption. We realize now, after 2 failed attempts, that things could go wrong, but we need to do everything we could to prevent that. So like King Solomon said in the Bible, there's nothing new under the sun. We've gone back to Pearson VUE centers. We're able to secure time in April of this last year, April 15th, and we're able to accommodate everyone who had been scheduled and signed up to take that exam last July was able to take it if they wanted in April. Some who chose to could take it, as I know some of you are thinking of taking this or set up to take this in a few days, also at the Pearson VUE Center. And it went very well in April. As a matter of fact, when we did all the statistics on it, people had exactly the same experience. It looks like people may have even done slightly better. We wonder if that's because we decoupled for that year the order where you do the oral and the written exam, and maybe double studying for people helped better. We know that we got a really good exam and people had a fair exam, and that we're able to, their certification will mean the same as anyone else. So we're back to the old, and we're not doing the virtual for now with that. But what about the certifying exam, the oral examination? Well, if you watch on TV and you see Grey's Anatomy, it looks something like this in a hotel room with a bed right there. And this is really not accurate at all. Even when we're using hotel rooms more recently, we haven't been doing it this way for some time. We specifically have hotel rooms with suites so that you're actually in an office type setting and walking in. That said, it's creepy. It's really creepy to go into a hotel room. I've done it. Anyone who's done it, it's kind of an odd thing. I remember when I was back at the University of New Mexico, Jim Goff ran our mock orals, and he's one of the attendees. He would get up and Eminem and say, "You're going to be in a hotel room someday and someone's going to ask you." And it was just, I always thought it's such a weird thing that people would say that our futures as surgeon depends on being in a hotel room. It's just not normal. So we've gone over to this virtual format, and you see a picture of me imagining it. That's actually Cody Yorman, who works with me here in Tulsa, pretending that she's one of the people taking the exams. But we do it virtually, and it's been very successful. And I'm going to show you some of the ways it's been successful. One thing I'll tell you is the examinees who take it much prefer this format to the old format of going into a hotel room, running around, stepping in stuff, showing up out of breath. They feel like they have a better experience. And frankly, I think when the candidates are having a good experience, it's a fairer exam. So I'm really happy with that. There are a lot of similarities between the virtual exam and the old in-person exam. You still get a pre-exam candidate briefing. You still get a check-in process on exam day. You got 3 exam rooms with 2 examiners per room asking you 4 scenarios, so 12 total. And there's ABS staff available to answer questions. The big differences are there's travel versus no travel. There is less stress, I believe, although we can't study it, but it appears to be a little more pleasant experience for the examinee. The examiners, those of us getting it, miss some of the camaraderie of being in person, and we're figuring out ways we're going to be able to have that in the future and still give this exam. And there's some potential technological issues with a virtual exam. You can have a thunderstorm, someone's computer cannot work right, their battery can run out. It's rare and it doesn't happen much. And frankly, we had things like that with the in-person exam too. An airplane flight could be canceled and other things could happen. So there's some differences, but really happy with what we've been able to do. I think this is a real victory on the part of our staff in the American Board of Surgery. We normally, in a week-long session, it's 3 days, we're able to give 300 exams. We could examine 300 candidates in those 3 days in our old style. You can see here, because we had to make up for some missed time from last year, we're able to actually ramp this up. We're able to do 466 and 460 candidates the last 2 sessions that we gave of this. So it really amplifies well and is very doable. So I think there's a lot of efficiency to it that we like. I'm just going to add, because you're going to hear more tonight in your webinar, I want to remind you, we've given you the answers. It's different back in my day. If you have the SCORE curriculum outline, you know what you're going to be asked. You know the subjects you need to know. It's the way it should be. And we're seeing the higher and higher pass rates, particularly on the written exam. And I believe it's because you know what to study for. We're being a lot clearer about what we're going to examine. I think it's a fairer test, and it's more accurate to what you need to know as a general surgeon. So the future of the American Board of Surgery exams, the certifying exam, the oral exam, we're not going back to hotels. It's going to stay virtual. It may look different than the virtual does now. We may find better ways to do it, but I think there's no chance really I see that we're going back to the virtual exam. For the written exam, the QE exam, it's going to be in person, at least for now, until better technology makes it alternatives feasible. So I'm going to say boomer sooner, and thank you for the opportunity to present. I'm sorry if I went a little bit over. I'm going to turn it back to you, Dr. Fong.
Thank you, Dr. Nelson, for the incredibly informative session. Next up, we have Dr. Yewande Alimi, who is an MIS fellow from Stanford, who will talk to us about how to prepare for the qualifying written exams. The mic is yours, Dr. Alimi.
Thank you. And thanks again for inviting me to give this portion of the talk. The first thing I'm going to say is that breathe easy. I will also say that if your test is on Thursday, the session is not for you. This session is a long game session. And so just want to be sure that, folks who are here today in preparation for their test, don't think that they're going to learn everything in the next few moments, okay? So how to prepare for the qualifying exam. So this is the written portion of your boards. This is the, what's been simulated over the last couple of years that you've been taking it with the app site, and will ultimately be what qualifies you to take your certifying exam. I have no disclosures. We're going to go briefly over what the exam is, how to and when to register, and ultimately how to prepare for this test. The qualifying exam is offered annually. It is offered at the end of the year, usually around this time. Similarly, July 15th is the test date for this year. What's interesting to know for PGY3s who may be considering taking the test as a PGY4, there are specifications for you to be able to do that. I've included the link here for you to go to the website to make sure that you have all of the requirements to do that, but you can be eligible. And for the most part, you can be eligible based on everything, barring your case numbers. And so you don't have to have all of them at the time that you submit, but you do ultimately have to have them done, and you can resubmit a final case log. But go to that link if that's something that you're interested in. The test itself, it's a 300 multiple choice questions in standard years. And I say this for those who experience an element of the COVID time period, but for what it will likely look like in the years to come is an 8-hour-long test with 4 115-minute sessions. Each of the sessions, you take the test, then you have an optional 10-minute break after the test, and then you have a 40-minute break between the third and fourth sessions. This is a nice little reprieve to sort of take a breather, to grab a little quick bite to eat. So that means bring something along with you for lunch. Most of the test centers don't have somewhere that you can get something super quickly. So bring a lunch with you when you do take the test. The registration and the requirements, it's certainly not a cheap test, but the fee to actually apply is $525. This is the information I got off the website today. And then the fee for the actual test at the Pearson Center is about $1,400. The requirements based on your training are can be found at their website, and I've listed that here. So this could be sort of a one-stop shop for you guys as you're figuring out what to do. You're going to need your operative logs. You're going to need a signature from your program director. And for those of you taking the test as a PGY5, needing your operative logs to submit for the test, take that into consideration. So keep your logs up to date, because you're going to want to start applying for this in about the January to March period of your PGY5 year. You'll need the documentation of your ACLS, your ATLS, your FLS, and your FES. And there were accommodations made for COVID because these tests weren't being given in person. So go to the website just to make sure when and if these accommodations will continue to be made versus a lot of these testings are starting to go back live, and so they may not be making these accommodations anymore. And then a medical license isn't required for the QE at this time. They have a couple of new things for 2021. So once all of your information is submitted, you can then go ahead and complete the second step and register for the exam while your application is undergoing review. There used to be a time lag in between when you submitted your test and when it was approved before you could then go onto the Pearson site. This sometimes, I think, why the ABS has changed this is that people sometimes felt boxed out of being able to go to a Pearson test center that was more local to them. And so you are able to go schedule your test right away. And because these testing centers have limited capacities, everybody's taking these in person. You want to make sure that after you submitted all of your information that you go ahead and do this, since this is now an option. So that is something to note. This is also highlighted on their website so that you can go and review that. So now let's talk about the actual test. Predictors for people doing well. Scoring below the 35th percentile on the app site at any time during residency has been previously documented of people not doing well on their qualifying exam. In addition to this, scoring less than a 200 on USMLE step 1 was a predictor. And I think that, you know, these two predictors are based on the fact that it's a multiple choice test, and these are demonstrable sort of high stake multiple choice tests, the USMLE and the AppSite, that the data has been translated to the QE. AppSite scores are a useful predictor of QE scores and outcomes, but they don't predict passing the certifying exam. You know, people can, you know, maybe be a more difficult written test taker versus being, you know, having that conversation with somebody on the other end. So while doing well on the AppSite is a predictor of performing well on the QE, performing poorly on the AppSite doesn't necessarily associate with doing poorly on the QE. And what that is to say is that, you know, just because you may have had a bad AppSite year once or twice or a couple of times, making sure that you're focusing on the long game, that you're doing some of the things that I'm going to talk about in the next couple of slides, doesn't mean that you're not going to pass your QE. Okay, don't let 1 year sort of define you and what you think you're going to do on your QE. You have many shots to sort of, you know, learn from those areas. I think that some of the things I'll talk about next are important for how to make sure that you do well ultimately on your QE. So this is all about the long game. You know, you're not going to learn everything overnight. It is a lot of information. You're going to go to the SCORE website. You're going to see what they want you to know in the different regions of the different categories. The ABS has a great chart that sort of tells you that, hey, you know, 12% and 15% of the tests are going to be about the abdomen and the alimentary tract, you know, so study accordingly, right? The test only has about 2% of transplantation. So, you know, you don't need to be studying all of the immunology things, you know, for 2 weeks because it's only 2% of the exam. So use these benchmarks here to guide how you're preparing for the test. And as previously mentioned, the SCORE curriculum is there for you now. You know exactly what the QE is going to test you on. You know exactly what areas they're going to highlight, how they're distributing these questions. And so those are the things that you should focus on. And when I say this is a long game, this is something that you need to be doing throughout your academic time, throughout the years. This isn't something that you're going to learn in 4 weeks before you take the test after you graduate from residency. I wish it would be possible to do that, but the reason why we're in this training program is to learn all of this information in this amount of time. And so it's really all about the long game. There are a plethora of resources, and I could say, hey, like these are the resources that I use. Everybody learns differently, and everybody is going to be able to glean information from different areas, and you need to pick a couple and have those be what you're using. So what I recommend to do is to create a plan, okay? Your annual plan should focus on one, a reading plan. Choose a text, choose one that you want to be like, this is what I'm gonna go through. So either you're gonna say, I'm gonna go through Cameron's, I'm gonna go through Greenfields this year, but choose a text and have it so that throughout your year, you're going through that information and you're taking notes somewhere, okay? Like what you don't wanna do, and maybe you learn differently, what you don't wanna do is though, feel like you have to go back at the end and read all of Cameron's again to remember everything. So what I thought was really beneficial is throughout the year as I was reading, I would take notes on Cameron and I would put it in a document. I actually put it in a document called True Learn Pearls, because that ultimately was the place that I also put in like things that I learned from my True Learn questions. And that's where I took my notes, so that when I got to closer to the time I was taking my QE, though I did take my attempt to take my QE twice, so I studied twice for it. So, you know, that's what I went back to, you know, because you don't want to reinvent the wheel of your preparedness. Like you want to make sure that you can sort of go back and be like, okay, these are the things that I tend to forget. These are the highlights that I want to remember. And then for your AppSite preparation throughout the year, you know, sort of stagger what you're doing. So whether or not you're going to use the Pfizer book or you're going to use the bigger Pfizer book, use that time to be taking those additional notes and supplementing your reading plan. And then questions. Ultimately, this is a questions test. This is I'm going to pepper you a question, and can you pick between 8 answer choices A through E? And people do differently in different contexts on that. And so how you've done on prior tests, remember what you did well. For me, what I took was that, okay, I had my AppSite from the year before. It said, oh, I didn't do so well on the pancreas questions, or, oh, I didn't do so well on the breast questions. So the next time that I went to prepare, I made sure I highlighted the breast questions and the pancreas questions, right? Because those are the places where I had shown myself to be deficient in before. Those weren't necessarily the ones for me, but that's an example. And then when you get to 3 to 6 months before the test, you want to follow up on all those notes that we've talked about. Review your weak areas, as I just talked about on the prior app sites. You get a great form from the ABS afterwards that says, hey, you did poorly in breast, or you did poorly in the abdomen. Go through those again and have that be where you're highlighting. And again, do questions. I think that all of these resources, you're going to get different things from them. I personally think ultimately at the end of the day, the review of the answers to the questions was actually what helped me the most. Sometimes the questions aren't greatly written. You'll hear from one person versus the other that says Ssat questions are great or score questions are great. I think the explanations of the questions are where you're really getting your bang for your buck. And so choose a question bank. You don't have to do all of them. I think that as you go on through the years, you can focus on some at the beginning, and then in the latter half of your PGY 3 to 5 years, focus on another one and continually be taking notes. Okay. Ultimately, this is all about seeing as many questions as you can in the amount of time that you're studying, reviewing your weak areas, because if they're your weak areas, those are the places that you should pay attention to. Remember how you study for your MCAT, or remember how you studied for your shelf exams. Remember how you studied for USMLE. Take the things that you did well then and make sure that you capitalize on that, but capitalize on making sure that where you were weak, that you're going to improve on throughout the years. And so in summary, we're all about playing the long game. You have to have a reading strategy for PGY 1 through 5 years. You don't want to bank it all to the last 4 weeks right before your test, because it's not going to be enough time, okay? Prepare a condensed study tool so you don't have to go back to the primary content for everything. When you have a quick question about like, oh, what exactly is it do I do for atypical ductal hyperplasia? It's okay to then go back to a book because that's a specific question, but you don't want to be doing that for every topic. And then questions, and again, more questions. This is really all about the long game. You're all going to do great. You're all super smart, but put in the time now so that you don't have to put in the really intense time in the 3.5 weeks before taking the boards. Thanks again for your time.
Thank you, Dr. Alimi, for the wonderful talk. Next, we have Dr. Salvatore Docimo from Stony Brook, who will talk to us about preparations for the certifying oral exams. Dr. Docimo, the floor is yours.
All right, thank you so much. Thank you, SST, for the obviously the invitation to speak tonight. Thank you for the introduction. So I'm here to talk to you about the certifying exam, which can be obviously probably one of the more anxiety-provoking parts of becoming a board-certified surgeon. So just a couple of disclosures here. I'm Boston Scientific Consultant, and I am a co-editor of one of the clinical algorithms in general surgery textbook, which I make a reference to in this talk. So just a couple of just general background information. For the most part, the board exam is 2 main parts. You have your written part, which Dr. Alimi just went over and did a fantastic job kind of simplifying and demonstrating how to successfully pass that. But then you also have the oral boards, and then you also have maintenance and certification. So, and of course, that's the part after you pass the 2 main ones and become board certified. So for the most part, the biggest thing or most important thing is preparation. So how do you prepare for this exam? There's no way you can prepare for it in a matter of a couple months, 2 months, 1 month, 6 months. It's just not going to happen. It's a lifetime of learning, and you're going to really have to spend some time during your residency to really focus on learning. And one of the most important things about learning is just having the ability to talk about what you're going to do and express what your plan is going to do. Because the important part of this is that someday you're going to be alone in a room with your patients, and you're going to have to explain to them how you came up with a diagnosis and what your plan is going to be, or you're going to have to explain to them how you're going to deal with the complication that they're dealing with or a loved one's dealing with. So this exam is an important part of what you're going to be doing for the rest of your career. So just looking at some of the timeline for the certifying exam, in general, in June, you would finish up your residency, take your qualifying exams, and then you will go on and move on to your certifying exam in about early September. You have a couple of chances over the next few years to take this exam. For the most part, all that's been kind of thrown out the window, and this is all kind of pre-COVID. So this has all been a little bit different. And thanks to Dr. Nelson's brief talk earlier on, I'm going to have to change some of my slides now, I think, permanently. So, but these are all good changes. They're not bad changes. Going to a virtual format, I have to agree, kind of lessens the anxiety level a little bit, and actually makes it more of a pleasurable experience, I think, for the participants and even for the proctors as well. So again, we just mentioned this, it's going to be going virtual, and I think hopefully this is going to be a permanent change. I think it's going to be great for the exam, but definitely for this year, obviously for 2021-22, the exam is going to be virtually given. What's important to know is that you don't have to download any software. You don't have to download Zoom. You're going to be able to run it off a link that they're going to send to you, similar to what we do for a lot of lectures. And I think the advantage of, by the time participants who are watching this lecture tonight get to the certifying exam, you guys are going to be pros at using Zoom and kind of navigating through it. So I think all those like little hiccups that we experienced earlier on are going to be kind of tossed out the window by the time you get to this exam. So there's the medical license requirement. A full and unrestricted license to practice in US or Canada is not required to take the certifying exam. However, the license itself will be required to have in order to have complete certification. And candidates who are listed who don't have the license will be listed as in the exam process. So you don't need a license to take it, but you just need it to be completely board certified. So you get one opportunity per year. All candidates are offered no more than one opportunity per academic year. And if you as a participant or a candidate for the exam fail to select a date, that will be considered a lost opportunity. So there is obviously some anxiety about, am I prepared? Am I going to do well, et cetera? You don't want to lose this opportunity, because even if you take the exam and you don't pass, it's still a learning experience. And the next time you go and take the exam, you're going to be that better prepared. You're going to be a little bit more comfortable. You're going to know what you did right and what you did wrong. So just take it as a learning experience. So definitely don't miss out on these opportunities, because if you miss out, it's a completely lost chance to pass the exam. For the most part, individual will be granted a maximum of 3 attempts within a 3-year period. And again, as we mentioned, one opportunity per year. Okay. So a little bit more of the details. What exactly is the exam? It's going to consist of 30-minute sessions times 3. And you're going to have about 2 proctors, 2 examinees in each room. Sometimes there may be other individuals in the background, but you're going to have 2 main individuals who are going to grade you. And you're going to have 4 cases per room, so a total of 12 cases. And again, this is important, such an important exam, because it is the final step toward your certification in surgery. And again, I'm gonna just quote this here, and this is all from the ABS surgery website. It's designed to assess a candidate's surgical judgment, their clinical reasoning skills, and their problem-solving ability. So that's an important statement, because I think what that's trying to show, and what I'm trying to stress here, is that, again, this is not something that you could just study in a couple of months and kind of coast through. This is all about your surgical judgment, your reasoning. It takes obviously an entire, numerous years to train, and that's why surgical training is such a extensive process, is because you have to start from day 1 of your internship and really kind of build upon a strong foundation, so that when you are presented these cases, you can come to a logical and most importantly, a safe conclusion on how to treat your patients. So so again, this is a lifelong learning process, but it's definitely something you have to start thinking about really from day 1. Now, in terms of what types of cases you'll get on the exam itself, the certifying exam is, generally but not exclusively aligned with the SCORE curriculum, which I do believe the majority of residencies now are utilizing SCORE as their curriculum for what they learned during residency. And a majority of the cases that are picked for the participants are designed or considered as core topics. Okay, and there's different types of levels of cases. You have the core topics, and then you also have advanced topics. And I'm going to give you a little bit more detail here. And again, all this information is available on all the links that I'm providing. So if there's some things that you filled out, you feel you missed, the slides are available to you. But then also these links are also you can download all this information on a PDF and really take your time to go through it. But looking at the core topics, and these are just diseases or procedures encountered in general surgery for which the graduate of a training course will possess significant knowledge. So these are basically what you're telling us, the majority of cases that you're going to get are going to be very common. They're going to be the trauma cases, the breast cases, even issues with gallbladder, biliary disease, etc. A few of the cases will be considered advanced, And these are diseases and procedures that are not consistently part of general surgery practice. And so just diving a little bit deeper into what all this means. So this is, again, just, I took this straight out of the pamphlet. There's no guessing here. They're really not trying to fool you. But if you look at this is a segment I took out from the pamphlet on what are considered core and advanced. If we look at the abdomen or liver, some of the core topics are hepatic abscess collections, neoplasms, and then if you go to advanced, cirrhosis, portal hypertension, and again, core hepatic abscess, how do you drain it, or what the procedure is, things that we probably already know, how to drain them, biopsy, and then more advanced procedures like segmentectomy, lobectomy, etc. So you can see that the majority of the problems or the surgical pathology that you're going to get on the certifying exam is going to be things that you're going to be experiencing commonly throughout your residency. So what about the details? I think most people always get a lot of anxiety of, okay, I have to, I know what to do, I know what type of procedure, but I have to describe all the little details. For the most part, yes, you have to be able to describe the common core procedures, and you have to demonstrate that you know some of the details. But for the most part, they say to use about the 40-second rule. So every time if they say, okay, how would you do that procedure? Use the 40-second rule. So you have to be able to describe the technique and how you would do the procedure in approximately a little bit less than a minute or so. If it's taking you too short or taking you way too long and you feel like you're stumbling a little bit, you probably need to go back and review that procedure because you may get an unsatisfactory score. And for the most part, again, when you're practicing, which we'll get to in a second, when you're practicing how to do these cases, make sure that the majority of these common cases or procedures you can describe in a 60-second or a little bit less kind of snippet. So how do you prepare for this exam? And again, it's a great quote: by failing to prepare, you are preparing to fail. So again, residency, you have to do a residency to be even somewhat prepared for this exam. But at the end of the day, you have to practice. Likely by the time you're completing your residency and you've done all your exams, you're going to have that body of knowledge to understand what you need to do and how you need to treat a patient. But you have to also now start to practice how do you properly express your plan to patients and to other individuals. So, for the most part, you want to be able to start understanding you're going to come up with your diagnosis, how you're going to treat the patient, and then how you're going to properly express this to the patient. And number one. So where does all your knowledge come through over the years? It's going to come from different textbooks, procedural textbooks, CSAP audio, your ABSCITE score, your ABSCITE exams, your preparation, etc. Whatever your source that you are going to use, you want to stick with it. So find a source that you find you're most comfortable with, again, from a textbook, even some of the board materials, and kind of stick with that. Don't have numerous types of sources. It's going to get a little bit confusing, okay? And you also want to have that go-to guide in terms of what to review when you're preparing for this exam and over the years. And as I mentioned, again, this is something you want to start preparing from day one. One way that I studied throughout the years was I would, read a textbook, different types of textbooks. I would take notes on them. And when I would read something new about a topic, I would just kind of add it into my previous notes. And by the time I was done, I had a massive binder of information, but that became my own personal textbook. And it would obviously, every time I review it, become more and more familiar. And that's something I actually even used and reviewed for the oral boards, okay? And this is an example of what I also started to do. I created these algorithms because when you get to an exam, an oral exam, and someone asks you or gives you pathology, in your mind, you want to have a kind of an idea of how you're going to approach each problem. And I'll give you a little bit more detailed information moving forward. But you can see that what I did was I took all this information for every single surgical pathology that we came across. I created these algorithms for the core procedures, annotated through my own notes, and created this large binder. And at the end of the day, this was the end result. It was an actual textbook that we published. So I know this is a shameless plug, but it is. But my point I'm trying to give you here is that by the time I was done studying throughout the years, I had my own entire textbook of information. So just kind of gives you an idea of how to best prepare for this exam. And again, most importantly, practice and practice and practice again. Start early. So again, by the end of your third, early fourth year, you're going to have that base of knowledge that you're going to need to do well in this exam. But again, you have to start to practice in terms of going through the algorithm in your mind, diagnosis, what's your treatment plan, what is your surgical plan, and how you deal with the complications and how you do the actual surgical procedure. So practice with residents, faculty, classmates, practice to your, run cases along with your dog, whatever you got to do, start practicing. And I think for the most part, by the end of your 4th year is when you really should start, a couple times a month. And then as you get closer and closer and closer to your exam, you're going to start practicing almost on a daily basis. So here's a little bit of general outline. So when you start getting closer to this exam, again, have that general outline in your head, how you're going to come across, approach each single case. You're going to have that initial presentation that someone's going to give you, and you want to kind of summarize that presentation in your mind. I put not a med student HBI because you don't need every single detail. You just kind of need the important parts, the pertinent information. Then, okay, how are you going to work up the pathology? Then finally, once you have that pathology, you have your diagnosis, you're going to say, okay, well, this is the management, which is likely going to be a surgical procedure. This is a surgical exam. So for the most part, you're probably going to end up in the OR at some point. And then always prepare for common complications. So have that in your mind. If I get choledochal lithiasis, am I going to need an ERCP, et cetera? Are they going to need a drain? These sorts of things. So have an idea how you would deal with basic complications, because you likely will come across a complication. Even if you do everything perfectly up to that point, you're likely going to get a complication. And again, the oral exam tests your problem-solving skills. And most importantly, I can highlight this, safe management of the surgical issues. So as long as your thought process is appropriate, you can come up with the correct diagnosis, you get them through surgery and the complications in a safe manner, you're more likely than not going to do well and going to pass. Be confident when you're in the room, and even the virtual room, but still be confident. And I say this all the time when people are preparing for the exam, just imagine that you're talking to a patient. The patient's going to come, they're going to give you their own, they're going to give you their clinical presentation. You're going to say, okay, this is the test that I'm going to get. This is how I'm going to work you up. Then you're going to get to your diagnosis, and you're going to tell them, say, listen, we're going to take you for XYZ surgery. These are the risks of surgery, and these may be some of the complications. So in your mind, just kind of think that you're at the patient's bedside. State what you're going to do, how you're going to do it, and why you're doing it. And I think most importantly is do not give answers based upon what you think the examiners want to hear. Because if you tell them that you're going to do a complex surgical procedure you've never done before, you're probably going to fail, because you're going to get stuck early on in the test question, and you're not going to be able to recover. So just do what you do that you will normally do on a daily basis. Best advice: if you have a bad case, this is my best advice I give to everyone. You have to let it go. You have to just let it go. You can't keep harping on it. If you have a bad case, you have to move on to the next one, because you don't need to pass every single case. You don't have to pass all 12 in order to get to pass your certifying exam. So important thing, don't get flustered if you have one bad case, because you never know. You probably likely pass it, and you're just not being as confident or giving yourself enough credit. So day of the exam, again, as I mentioned before, I'm probably gonna have to change some of these slides, not permanently, but we used to, you have to bring your ID cards, your admission card, no bags, purses, cell phone. So a little bit different now. When you get into the virtual room, they're probably gonna have you look around the room, make sure there's no books or papers or anything near you. You still have to show us some identification. You can still have a pen and paper nearby, a bottle of water, and some type of watch for time management, no smart watches. So overall, even whether you're in a hotel room, which probably never gonna do that ever again, but if you're in a virtual room, very similar to what we talked about. And again, the exam, there's gonna be 3 virtual rooms, 30 minutes per room, or 1.5 hours each, 2 examiners per room for a total of 4 cases per room for a total of 12 cases. So that's the breakdown. So for the most part, most likely the cases that you're gonna get during your oral exam, you already have them somewhere in your case log. So just be confident in that you've probably seen the majority of these cases already. Each examiner will independently grade every scenario. And again, the final grade, whether it be pass or fail, is based upon your overall evaluation of all the examiners. So as I mentioned before, you don't have to pass every single exam. If you pass the majority of them, you're still going to likely be able to pass overall. So just a couple of last kind of parting ideas here. Approach each case in a very organized and rational manner, as I mentioned before. Just imagine that you're sitting in a room with your patient, and just really just think about you're talking to a patient and come on, and in your mind, always have that stepwise way to approach a problem, whatever that may be. What's the initial pathology or what's your differential? How do you work it up? What's your diagnosis? What's your plan? And what are some possible complications? Let's see. And then also recognize personal limitations in your knowledge. As I mentioned before, do not start talking about, don't tell the examiner what they want to hear. Just talk about ways that you know how to treat that pathology. And then really overall, use good surgical judgment. And again, be very, very, very safe. As long as you treat the patient in a safe manner, you're probably going to do fine during your exam. And a couple other things I want to just point out here. These are some of the scores from the previous years. As you can see here, first attempt pass rates have been pretty consistent. The data from 2020 was approximately 85% pass rate as well. So fairly consistent pass rates throughout the years. And then finally, these are your dates. And again, all this information is available online. And these are all the links, and all the slides are available online. You can feel free to go and kind of, cut and paste them as well. So thank you everyone for your time. And if you have any questions at all, feel free to send me an email. And thanks a lot for letting me speak this evening. All the best and good luck to all of you.
Thank you, Dr. Docimo, for a great talk and immortalizing Frozen's theme song for SSAT.
Anytime, my pleasure.
Session. And finally, before our mock oral scenarios, we have Dr. Tim Vreeland, who is a surgical oncologist at Brooke Army Medical Center in Houston, Texas. He will talk to us about contingency plans if you fail either the qualifying or certifying exams. Dr. Vreeland?
Yeah, thank you. Thank you for the opportunity to talk today. So as you said, we're just going to talk a little bit about what to do if you fail the qualifying certifying exam. This will be the shortest talk because I think there are some kind of psychological things that you need to do, but beyond that, it's very similar to the approach to the first time you took the test, which has been covered very thoroughly, I think. So a couple disclosures. I work with the Behind the Knife podcast, which has been mentioned in the chat, and there's a lot of resources from them on both the written and oral boards. I have started working a little bit with Caliber boards, which I wasn't going to mention, but then got mentioned. So that's a new program that offers the opportunity to do mock oral boards. And then I work with a company called Online MedEd that's more for medical education than resident education. So if you find yourself in this situation, I think a couple of things to keep in mind to really remember are that most people are going to pass. So most people that fail the first time will pass. The pass rates for the qualifying exam are 63 to 68% the last few years for people who are not taking it the first time, and then 80 to 85% for the certifying exam, which is roughly the same as people taking it the first time. So just because you fail the first time, don't get discouraged. You probably will pass the second time or the third time. Again, the vast majority of people are going to pass. And again, with that in mind, this will just be a small bump in the road in a long road of surgical training and being a surgeon down the road. So it's not the end of the world. It's just a bump. And again, once you're board certified, no one is ever going to ask you again how many times you took the test. So, I think that's the biggest thing, is just keep in mind that if you fail the first time, it does not mean that you're done. You have multiple attempts, and the vast majority of people are going to pass. So things not to do: don't compare yourself to your classmates or other chief residents. That just leads to unnecessary discouragement and really has no bearing on your journey to get to a passing score. Don't torture yourself trying to figure out which scenarios you failed. That, I think, is a real trap, and people spend a lot of time doing that. And the reality is you're going to remember one or two of the cases much more than everything else, but that may not be the one that you failed. So really, there's no sense, particularly I think this is for the oral boards, in trying to go over your test over and over again. Certainly don't call the ABS and ask them to change their mind or try to argue with people about it. That's not going to help. And I think, one really key thing is don't hide it from others. I think people are a little bit ashamed if they have a fail and they don't want to tell people, but I think sharing it with your colleagues, with your classmates and people that you trust, I think is very worthwhile, because that's a way to get more help, and just you need to kind of talk to somebody about this and bounce it off people that have been there and people who have kind of been with you throughout your training. So things to do, I think, take a little time away. So don't try to start preparing for next year's test immediately. I think just taking a month off and sort of putting all this behind you is probably the way to go. And then really you have to be honest with yourself at some point and kind of own your areas of improvement. So for the QE, I think that's looking for your knowledge gaps, really looking at, where did you do poorly on the AB site, and is that correlate with where you think you may have done poorly on the written boards, and really understanding where your weaknesses are there. For the certifying exam, I think there's two aspects. So there are, certainly you could have knowledge gaps that could hurt you on the certifying exam, but often that exam is failed for stylistic issues. So, not sort of playing the game, taking the test correctly, certainly things like being argumentative, or just, taking too long to get into the case, things that sort of people who have done a lot of these can pick up on if you just do some practice sessions. But really focusing in on where you can improve, I think, is important. And then, a lot of times you'll be a staff at that point or a fellow. And so you got to find time to study. So you got to find a way to protect your time to study, talk to your program director if you're in fellowship, or to your partners if you're in practice at that point, and really try to block off some real time to study. And then have a plan of action. So, this was talked about a little bit, but, make sure that you're being thorough and covering every topic. And I think using the percentages, the ABS publishes what % of the test is made up of which topics, using that to help you divvy up your time, but then make a concrete plan and then stick to it. So, I think whether you fail one exam or the other does affect a little bit of how you approach it, right? Because they're very different tests. So for the qualifying exam, I think it's very similar to the AB site, but if you've done poorly on the AB site and you failed your written boards, then you got to do more or something different this time to prepare. If you're weak on a topic, you may have to go back to a textbook. I think, this was well summed up that reading a textbook throughout residency is a great idea. Trying to read a whole textbook while preparing for this test is not a great idea. But if you know specifically that you're very weak in one topic, then going back and reviewing Cameron's for that specific topic might be worthwhile. And again, taking notes while you read a textbook and reviewing your own notes is key as well, I think. And then I think using one review text to make sure you're being comprehensive is useful. Sometimes you'll kind of spend all your time on the things that you're thinking of, and you'll forget to study a few topics. So having a broad framework through a review text is important. And then again, making a plan, making a realistic calendar to cover everything that needs to be covered, and then stick to it. And when your time runs out for a topic, you got to move on. That's kind of the same advice I give for people studying for the AB site every year. And then some resources that I think are great. A lot of these have been mentioned. So obviously SCORE, there's, I think the reading on SCORE is a little too comprehensive for immediate test study, but the questions are great. The Pfizer book, which I think most people know about, but I use that every year for the AB site. And I studied for my written boards the exact same way I studied for the AB site every year. And it was all based on the framework of Pfizer. And I did the same thing where I took notes and had a big binder of my own notes that I studied from, but it was honestly based on the order of the Pfizer book. So it was very much based on that framework. And I think that framework's very useful. Behind the Knife has a ton of great resources. They have their own review book now. And then again, they have podcasts around the AB site and around oral boards. So I think, look them up. They have a revamped website and a lot of great resources there. And then CSAP, I think personally, I don't think CSAP is great for the boards. I think some of the information is a little too new, but I do think that there are, questions there, and there's an audio companion. So it just kind of all depends on what you prefer. And then the certifying exam, this has been covered, but the flow charts have been super helpful for me. I sort of lived this twice. I did the general surgery and then the Surg-Onc boards, which are very similar, just slightly different topics, but creating those flow charts and going through them. And I didn't realize that I was giving a plug on this, but or that one of our panelists is involved in this book. But I use this book as the framework for my flow charts, but I did create my own. But I think it was a really nice framework, and I recommend this book to everybody getting ready for the oral boards. But making your own flow charts, and what that does, I think, is it allows you to do mental reps of the oral boards without necessarily having to be across from somebody. You can just run through that flow chart in your head over and over again. And that I think really helped me for the oral boards. And then review major operations. And I think this is particularly the operations that you haven't done as many times. Again, it's not going to come up that often that it's an operation you've never seen before, but there may be one or two, you may not do a lot of vascular, and you might have to describe a carotid. So I think just knowing the basic steps, and again, being able to describe that operation in 45 seconds, I think is really good. But, focus on the operations that you don't do, or maybe you didn't do as much in residency. And then again, I think getting honest feedback about your style is really important, because I think that that's where people get into trouble when they fail the certifying exam, is that, they have some stylistic issue, whether it be that they're kind of giving more information than they have to, and that information is wrong. I see that a lot from residents in mock orals. You don't have to give information that you're not entirely sure of unless it's, asked for. And then sort of arguing, I think, is a big problem. I think that's where people get in real trouble, and that can have this kind of momentum of you're becoming argumentative and then not having a good flow with the examiner, and that can lead to a fail for sure. So I think getting people who have experience looking or kind of doing these mock orals and doing a bunch of them and getting feedback on sort of not just your knowledge, but really your style of how you're answering the questions is very important. And then consider a review course. So review courses, I think, are not necessary always. And there's actually this paper, some data saying that review courses don't actually help. But I think if you failed, then you have to kind of, again, don't do the exact same thing you did last time. So if you didn't take a review course, it might be worthwhile taking a review course. There's a bunch of them out there. This is just a couple of them. And everybody knows about Osler, of course, which again, you get mixed reviews on all these things. But I think if you failed, then it's probably a good idea to get more help than less. So, and that's all I have for that. And then I think, Dr. Fong, we're going to move into the oral board scenarios.
Thanks, Dr. Vreeland.
Yeah.
I wanted to introduce our volunteer as well as Dr. Vreeland, who is going to be providing a breast type of scenario. Again, these are not sponsored by the ABS. They were never approved by the ABS. But I specifically would like to thank the two residents that volunteered their time. You can imagine it's not very easy to sit in front of close to 150 people doing this. So first will be Dr. Mitsakos, who is a PGY4 now at East Carolina University, Brody School of Medicine. He's actually going to surgical oncology, so he will be applying soon. So that's an area of interest for him. So Dr. Mitsakos, if you can come on.
Thank you, Dr. Altieri, for the opportunity, and I'm glad to be here. Thank you for the honor of the SSAT. I'm more than happy to be the volunteer.
All right, you ready to go?
Yes, sir.
All right, this is what one of the examiners in my board said to me, which I thought was great advice. He said, just pretend like you're in the doctor's lounge discussing a case with a partner, which I think is really good advice for the oral boards. But all right, so your next patient in clinic is a 45-year-old female who recently had a screening mammogram that noted some architectural distortion, and she was sent to you for consultation.
Yes, sir. So I will start by, of course, going to see the patient and get a history and a physical examination. The history mostly will be on risk factors for breast cancer, including family history, personal history of breast biopsies, personal history of estrogen exposure, both age of menarche and menopause, gynecological history, if she is pregnant or if she's had any pregnancies in the past, and also any medications that she's on. And then, of course, I will need to see if there's anything palpable that the patient has noticed in the breast. If there are any skin changes, any nipple discharge, and of course, the rest of the basic examination.
Okay, yeah, so she would be considered average risk, no red flags on your history, no family history. And on exam, you feel nothing palpable, and her node basins are normal as well.
Perfect. So after I have evaluated that, I will talk to the patient about proceeding with a diagnostic mammogram. At this point, I will make sure I review any previous mammograms that she might have had, and the diagnostic mammogram will hopefully show me a BI-RADS, I suspect.
Yeah, so this is, she has that architectural distortion at 12 o'clock, and it's read as BI-RADS 4 concerning.
Okay, so then I will see back the patient at the clinic, and I will tell her that with the BI-RADS 4, we have a fairly moderate to high suspicion for breast cancer. So the next step would be to do a corneal biopsy, which, since this is not palpable, would be under radiological guidance. So I will refer back to radiology for the corneal biopsy.
Okay, so that's she agrees to that. She goes down, she gets her core needle, and the biopsy comes back as atypical ductal hyperplasia. She's back in your clinic, wants to know what to do.
Okay, so I will tell her that atypical ductal hyperplasia puts her at a relatively higher risk for breast cancer, about 10 to 15%. And after that, I will tell her that the recommended procedure would be to remove that with an excisional biopsy, which would probably also be marker guided through a wire that the radiology probably has already placed. Usually when they do the biopsy, they put a marker and then they can do a wire the same day. And I will get some basic preoperative labs so I can do it in the operating room.
Okay, she agrees. Her labs are normal. You take her to the operating room. You do your excisional biopsy. Anything you want to do in the room or before you close with that specimen?
Yes. So when I take the specimen off, I will make sure that I mark the cavity in case we find anything different in the specimen that will need further either re-excision or further radiological therapy. So I will put some markers in the edges of the specimen. Okay.
So your final specimen comes back with ADH, no other concerning pathology, but the margin is positive.
Okay.
She wants to know if we need to do anything else.
Okay, so with ADH, she has a higher risk, as we said. However, we do not need to re-excise this margin. What we need to do is I will refer to medical oncology for consideration for hormonal therapy.
Okay, sounds good. All right, so same scenario, but now the biopsy is LCIS. Are you going to do anything different for her?
If it's simple LCIS, no, I will not do anything different. She does not require re-excision. However, I will tell her that LCIS is not a premalignant lesion in and of itself. It confers it to higher risk to have an invasive breast cancer in either breast. And the options here would be either an active surveillance with higher, decreased timing between the mammograms, or to do again a 5-year period of risk reduction with hormonal therapy. And another option would be bilateral mastectomy, and these are things that would be discussed probably with a patient in a more individualized fashion and in a tumor board.
Okay. If it's pleomorphic LCIS, are you going to do anything different?
If it's pleomorphic LCIS and the margins are positive, then I would excise it to 2 millimeter margin. So I would go again to the operating room and do a re-excision to the involved margin.
Okay, great. Okay, so let's go back to clinic, and now your core needle comes back with DCIS, and she wants to know what you're going to do.
Yes. So the treatment at this point for the DCIS, it is a premalignant lesion, and I will tell her that we will need to remove that, and that she will need post-operative radiation therapy for that in order to decrease her risk of local recurrence. So I will again do the same thing, take her to the operating room again with wire needle localization.
She says she absolutely doesn't want radiation. She wants to know if there's any other options for her.
Okay. The other option for her would be to do a simple mastectomy. But in this case, I would need to also do a sentinel lymph node dissection, because in case the DCIS specimen shows invasive cancer, we would need to have staged the axilla.
Okay. So now let's go back to clinic, and now the core needle shows an invasive ductal carcinoma. It's grade 1. Do you want to know anything else on the pathology report?
Yes. So on the pathology report, we would need to know her estrogen, progesterone receptor positivity or negativity, and the HER2/neu receptor positivity.
Okay. So she's ER/PR positive, HER2 negative. What surgery would you offer her?
Okay. So she's an early stage breast cancer positive on estrogen. So we would need, I would offer her breast conservation therapy, which would mean, again, partial mastectomy with a lumpectomy, as we said, with sentinel lymph node dissection in the same operation, and postoperative radiation therapy, and the hormonal therapy, anti-estrogen, per the medical oncology. The other thing I will tell her is that since she has early breast cancer, I would do Oncotype screening for her to see her risk for recurrence in case she need chemotherapy. And I will talk about that in the multidisciplinary tumor board.
Okay. And if, so you have this woman, her final path comes back, it's a T1C, and you have 1 out of 3 positive lymph nodes. So T1C N1A, she wants to know, does she need more surgery or not?
And a quick clarifying question, the N1A was from the sentinel lymph node, or was it
Correct.
clinical? Was
One, no, not clinic. She's still clinically negative, but one of your 3 positive, or one of your 3 sentinel nodes came back positive.
So then I will counsel the patient that the Z11 trial actually showed that patients in her category that have early small breast cancer, T1 breast cancer, she has with only 1, and actually even if she had up to 3 lymph nodes, she would be a candidate to just observe the lymph node basin instead of doing an axillary, a completion axillary lymph node dissection.
Okay, great. All right, that's 7 minutes easily. So yeah, I thought you did very well on that. I think that's, you know, that's kind of a common scenario to be ready for. It's not just breast cancer, but these pre-malignant lesions too. And that's, you know, you may get similar scenarios with like abdominal pain, where I can use one intro vignette to test 5 or 6 diagnoses. And so kind of be ready for that, where they may change the scenario. Let's go back to the beginning. Now it's this. Let's go back to the beginning. Now it's this. So, you know, those can be a little bit flustering because you're like, whoa, you know, so just, I think you did a good job keeping up with that. You know, and I thought you answered very reasonable answers to everything. Again, I think, you know, you probably, because you want to do Surgeonc, you're a little more interested in this. So, you know, you gave some information that you didn't necessarily need. So for people who listen to that and said, whoa, I don't know all that stuff, that's okay, right? I mean, you don't have to talk about, again, you don't have to like talk about Z11 as long as you sort of have some idea whether or not to do sentinel nodes. And to be honest, I give that scenario a lot and I don't usually get to that point. We were just sort of moving along pretty quickly. So I sort of got to that point, but you know, I think you did everything right. You gave all the right information. I didn't have a whole lot to add, honestly. So I don't know if there are other panelists who wanted to comment.
I thought that was great. Thank you both, Dr. Vreeland, Dr. Mitsakos.
Yeah. Oh, sorry. One thing I wrote down was you can comment on specimen mammography in the room. So that's kind of what I was trying to get you to say, but you talked about marking the cavity, which is fine. And again, like you don't have to get everything right? So I'm not going to fail somebody because they didn't talk about doing specimen mammography. I just kind of, a lot of times you sort of throw out a hint and sort of see how much knowledge the candidate has, just to see how sort of superlative they may be when they pass, but you don't fail for getting one little thing like that wrong.
Yes, sir. Yeah.
So that was a clear pass.
Dr. Alimi or Dr. Docimo, do you guys have any other comments?
Yeah, great job. I just wanted to double highlight that this is a very common setup where we start with the diagnosis and they sort of pivot on multiple trees. So, and breast is one that they can do that really easily with. And so this, honestly, literally watching this scenario is something you should definitely do.
Yeah, I agree. And I think the answers, you know, your answers were really nice, concise, and simple. And I think that's always the most important thing. And there was definitely some points in time where you might have wanted to get that information repeated. And I think that's totally fine. I think a lot, you know, from that perspective, if there's something you want clarified from the proctor, you know, feel free to ask us to repeat the question or what that piece of information was previously given. So great job.
Thank you very much. And thank you for giving me the opportunity to be here. I really appreciate it. Dr. Altieri and Dr. Vreeland for the guidance.
Thank you, Dr. Mitsakos.
Good job.
Okay, so next is Dr. Deborah Keller and Dr. Carla Giustiano. Dr. Deborah Keller is a colorectal surgeon at UC Davis. And Dr. Carla Giustiano is currently a resident at University of Rochester in New York. And she will be actually the Colorectal Cleveland Clinic Fellow next year. So congratulations, and she's about to take her written exam in 3 days. So thank you specifically for being here and taking this time.
You're welcome.
All right, you ready?
Yeah.
Okay. You've been consulted to see a patient in the emergency department. It's a 35-year-old male with a history of ulcerative colitis for 2 years. He's had 3 prior admissions for UC flares and now having a flare with 10 to 20 bowel movements a day. He's presented to an outside GI and has been placed on prednisone, 40 milligrams a day, in addition to his maintenance mesalamine and 6-MP. He complains of abdominal pain and bloody bowel movements. He also says it really hurts to cough. Where do you want to start?
Sure. So I'd want to start with a thorough history and physical, and him specifically asking about more about his bowel movements and how much blood is in them, and more so about his previous ulcerative colitis history, including medications and any previous surgeries. And then also a physical exam, specifically looking at his abdomen and overall how stable he is.
Okay. He's failed Humira and Remicade. He's only had UC for 2 years. Right now, he's having 10 to 12 bloody bowel movements where he says he's filling the bowl. He's received 1 dose of Entyvio, and that was a week ago, and he's been bleeding since then. On your physical exam, he's ill-appearing and in obvious pain. He's distended. He's tender to palpation, but he doesn't have peritonitis. He has a low-grade fever at 100.8. He's tachycardic at 112. His blood pressure is low at 98/60, and he's satting 97% on 2 liters of oxygen. What's your differential at this point?
Sure. So my differential starts kind of in simpler cases like a UC flare, working towards fulminant colitis, and then most concerning specific to UC would be toxic megacolon. We also have to worry about other causes of colitis, such as infectious causes, including C. diff, Salmonella, Shigella, CMV, and so on, and things like ischemic colitis. Oh, that would be more rare in a younger patient.
Okay. So what do you want to do next to work him up?
Sure. So I would want to get labs and basic imaging. I'd want to make sure the labs includes white blood cell count and differential, CRP, lactate, nutrition labs like an albumin, at least get a KUB, and then also order the stool studies.
Okay, great. So the labs show he has a white count of 22. He has 85% neutrophils with a left shift, 8% bands. His CRP is 105. His lactate's 3.5, and his albumin is 3. Nutrition labs are still pending. On imaging, KUB shows no free air, just a dilated colon with thickened wall. So at this point, what do you want to do with him?
Sure. So I'd like to get more information with a CT scan, but I think in the meantime, as long as the CT doesn't show me anything that pushes me to the OR, I'm going to start treating this patient medically. He needs fluid resuscitation. He needs 2 large bore IVs. I would start him on antibiotics with Zipper and Flagyl. I would start him on high-dose steroids with 100 of hydrocortisone Q6 and admit him for serial abdominal exams.
Okay, and when you write the orders, doctor, for this patient who's bleeding, are you going to put him on heparin or Lovenox?
I'm not. I'm just going to order SCDs for now, and I'm going to monitor his labs Q12.
Okay, you get your CAT scan. The CAT scan shows basically that he has thickened edematous colon that is transcolonic. There's no skip areas in the colon. It's going basically from his sigmoid and rectum all the way to the cecum. There's a minimal amount of free fluid. There's no free air. So you admit the patient and you do your serial abdominal exams. And about 2 a.m. when the resident is doing the exam, thinks that the patient has gotten peritoneal, and you get called. How would you like to approach this now?
Sure. So if he's progressed now to having peritonitis, we'll have to go to the operating room. We would have had ostomy nursing mark him ahead of time in preparation for this possibly happening. And at this point, we would talk about consenting for a subtotal colectomy with an endoleostomy. Given that he has peritonitis and has kind of quickly deteriorated, we would talk about just approaching this open so we can quickly take care of him. And along with the distension, I'd be worried about doing this with an MIS approach. And so we would talk about him having an ostomy and then going over all the common risks like bleeding, infection, leaks, needing further procedures or surgeries, and so on.
Okay. And he tells you that he doesn't want the surgery if he's going to have an ostomy. How do you answer that question in that period of time?
Sure. I would tell him that the plan is for the ostomy to not be permanent, but that we cannot safely put him back together, that given the CT findings, I know that his rectosigmoid is not healthy and that I can't possibly make a healthy connection to it, but that the goal would be to get over this acute presentation, get him healthier, and then work later on towards reversing the stoma.
Okay. You take him to the operating room, you do exactly what you say you're going to do. You do an open laparotomy and you start to do a subtotal colectomy with an endoleostomy. Can you tell me the steps of the operation?
Sure. So after we prep and drape in the usual sterile fashion, we're going to enter the abdomen through a midline incision. We're going to mobilize the colon starting just laterally via the white line of Tolt, making our way once we mobilize the right colon, the left, and then finish across the transverse. Making and ultimately down to the sigmoid, and as much of the rectum as possible, paying attention to how viable or not his rectosigmoid is to decide where we're going to transect. And then we're going to leave as much ileum as possible in our transection just beyond the ileocecal valve. We're going to be careful with our mesentery because we know it's probably thick and inflamed and can bleed, and ultimately just resect down to whatever is healthy in the rectosigmoid. If nothing's appears healthy, then leaving potentially a stump for like a mucus fistula.
Nothing appears healthy. I didn't understand where you said you were going to transect distally.
Okay, so we would just leave a rectosigmoid stump with enough reach to bring down to the bottom of the inferior portion of the midline incision, where we can do a mucus fistula there.
Okay, so you do that. Post-operatively, the patient's staple line does fall apart, but no infection ensues because of how you implanted it. So when are you going to see the patient back and talk to him about reversal?
Sure. So we're going to wait at least 3 to 6 months post-op, make sure that there's no ongoing infection. We're going to look at his nutritional values and look at his weight and so on to see if he's kind of nutritionally repleted. We can also do a flex sig to look at the how healthy or not his rectosigmoid is. But we would start those conversations about 3 to 6 months.
Okay. And instead of finishing the case, when you're intraoperative, you stable across the terminal ileum and you start mobilizing your colon. Anesthesia alerts you that the patient's become profoundly hypotensive, tachycardic, and acidotic on the blood gas. How are you going to proceed now?
Sure. So as the patients become more unstable now, I'm going to kind of halt out where I am. I'm going to resect the parts that's already devascularized and plan on just leaving an open abdomen with an abthera, and I'd probably leave a drain in his rectum to drain that way as well. So he can go to the ICU to be resuscitated and continue when he's more stable.
Okay. All right. So we're going to stop there because of time. I think you did a great job.
Thank you.
So you hit on all of the major points. You didn't say too much. You said just enough. Does anyone else have critiques?
I think You did a great job. I think that she's exactly right. You were very measured. You were thoughtful in everything that you did. You counseled the patient appropriately. You were, you had a good pace. And I thought that you were very thoughtful with everything. I think that when she threw you a wrench, like, it's not that you didn't do the right things. It's that, and you like responded appropriately to the pivots. And so just knowing that, thinking in your head, oh my gosh, what did I do wrong? What did I do wrong? That's not what you need to do. Just answer the question in front of you. And you did a great job doing that.
Thank you.
Yeah, I agree. Great job. I mean, the summary of the case technique I thought was excellent. There's no, there wasn't more detail than you really needed. I love that you had the ostomy nurses mark the patient in the middle of the night. That's fantastic.
I should have said that earlier, but I was told I can sneak in extra. I can say, oh, I would have done this. So I would have done it with my initial admission order. I snuck it in hindsight.
And I think, just really quick, I think, as you mentioned before, I could see in the room talking to the patient when the patient's like, listen, if you're going to give me an ostomy, I don't want the surgery. Your explanation is basically, there was nothing complex about it. It's just a real down to earth explanation that you would give to a patient. And 99% of the time, that's the right answer. So nice job.
Thank you.
So there's a question from the audience. Christopher Patterson is asking, can you comment on calling consultants GI for this case in particular, but in others as well?
If you call consultants, I think that the examiners are basically going to tell you that the consultants aren't available, but they're going to want to know what you want from the consultants. So what would you want from GI? Would be my answer.
I also think that it's not just for GI. For example, if you have some complex vascular procedure, which you don't do that often, if you say that you're going to consult a vascular surgeon to come to the OR and do a procedure X or so forth, you have some basic understanding of the procedure. You don't need to know, like, what kind of sheet you have to use or what kind of graft you have to use, just some basic understanding. That's perfectly fine. They might say like vascular isn't available, and that's fine. And just what exactly do you want them for? That's completely fine as well, I think.
And I think that in that case, you should be honest. You should say that I don't routinely do this, but I understand that the steps are this, or my understanding is this. You can have the great Denali weigh in on that.
Yeah, that point is really key, that if you I remember personally doing that. I was like, this is not something that I routinely do in my practice, but as I understand it, this, that. And, they asked a follow-up question. They were like, do you do this in adults? And I was like, no, so it's just, it's totally fine to be honest with them, because they don't want, the core of all of this is, are you a safe and reasonable surgeon? They don't want you going rogue. Like, no, that's not something that I do. But as I understand it, this is what, and, I personally didn't think so yeah.
I actually really want to commend Dr. Giustiano and Dr. Matsakis for the courage to actually do this in front of everyone, because not only is it a good experience for everyone, it actually models who we want to be as professional surgeons, which is we share with each other, we share the good and the bad, and we learn on behalf of our patients. So I think you're a little braver, both of you, than I would have been. And I still wouldn't be willing to do this, I don't think, but I think it's great modeling. So congratulations.
So super quick, I just have one slide. I don't have a presentation. When people ask me how to prepare, my best advice to them is to practice, 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 and practice out loud. This isn't a book exam. It's not reading. Make sure that what you're saying sounds reasonable and you say it confidently. Trust your base knowledge. The best way to prepare is to do a surgical residency. You know your stuff. You have the knowledge. Just be able to pull it out. Be succinct in your answers. I think that Dr. Giustiano did a great job here. She's going into colorectal. She was asked a colorectal question. She could go on and on and on, but she stopped. She was thoughtful and succinct. And be ready for the scenario to change. Don't be lost patting yourself on the back when you answer something correctly, because then it's going to be, well, what about this? And what about this? And what about this? So you can't get lost in that time. Just be ready. It's going to change. Answer the question that you're asked and then stop talking. That's something that's hard to do, but you never know what your examiner is going to latch onto, and you're more likely to say something that's wrong and go down a rabbit hole if you keep talking. Be mindful of your body language when you're on Zoom, your cadence, the eye contact, your breathing, your posture, and just be confident in your answers. You're prepared for this. And just know that no one feels good about the test afterwards. The American Board of Surgery is not out to get you. These are your mentors, your chairs, the people you look up to. They want you to pass. They just want to know that you are a safe, competent surgeon, and you're going to do great. So that's it. That's all I have.
Well, thank you, Dr. Vreeland, Dr. Keller, Dr. Misakos, and Dr. Giustiano. Those are two very well executed mock oral scenarios. We're coming to the end of our session right now, and a reminder that this session is recorded and will be posted on the SSAT Residence Corner website for future viewing as well. So to close, I'd like to thank all our speakers and our mock examinees who took the time out to be here today. Specifically, I'd like to thank Maria Altieri, who's our committee chair, for her leadership on our committee and leading the webinar efforts as well. But most importantly, we'd like to thank LK Coughlin, who's our Director of Administration, who does all the behind the scenes dirty work alone and somehow managed to keep every committee member in check. And this doesn't happen without her. So thank you again, everyone, for tuning in, and good night and have a good evening.